Okay. Good morning, emerging voices, or good afternoon. I have no idea what time it will be in China by the moment you watch this. It's a pity that I could not join you. I would have loved to meet you all in person. But as you might have known, I was at the last moment told that it was better to stay with my newborn son and do my mother tasks. So I try to combine being again a newborn mother and at the same time also sharing with you the work which I did together with colleagues here in the Institute and talk with you about analyzing health systems and health systems dynamics. I have understood that all of you already got the publication upon which this presentation is based, so probably most of what I will tell you now is already known to you. I will try to keep it short, highlighting only the most important elements, or what we consider the most important elements of this publication. And maybe I might have time later in the week to discuss and chat and have a Q&A session with some of you later about questions you might have after having read the publication or having listened to this presentation. So these are a couple of the most recent publications on health systems. Health systems continues to be an important topic in the present academic scene. Not only health systems as such, and what does it mean to support health systems or to strengthen them, or to build them, or whatever term you can find, but also more and more recently there are publications on the politics and policies of health systems and how do health systems appear in global health policies. And one of the publications we ourselves made even about how health system frameworks fit into the political context there. So yes, it is still important to talk about it and to understand what it means when we talk about health systems, and to understand a bit the different ways of how you can look at it. This slide looks very complicated, but comes from the publication we just made about health systems and their evolution in the political context. And I want to highlight only a few important elements out of it, which show how health systems have been important in history over times. When I think we say global health really started, you could say, with the creation of the WHO and the definition of health as something more than just absence of disease, but the broader also well-being aspect out of it. And then a very important moment also for health systems, because it talked very much about primary care, was the Alma-Ata Declaration in 1978, which was very soon followed by a whole discourse that there was no money to fully fulfill the aspirations of Alma-Ata and that we should go for a more selective approach, which lasted long. And then I think another important landmark was 2000, when we had the Millennium Declaration and the Millennium Development Goals, but at the same time 2000 was the time of reappearance of health systems in discourse and in thinking as something being important. And from 2000 on you see an increasing number of publications on health systems or on elements of health systems. And then the latest landmark is, of course, this symposium on health system research, which you're now presently attending. So yes, there are many frameworks which say something about health systems, and you could group them. They have different functions. There are frameworks which try to define what is a health system and what are its goals and its functions. And here you see two of them of the WHO. But there are also frameworks which try to analyze a bit more what is going on in health systems. And complexity is an issue which has evolved as something recognized as important and very relevant for health systems, because health systems are presently seen as complex systems, and what that means we could discuss longer about, but is also something which is very important in our vision. And you can visualize complexity in many ways, of course. This one on the left is the one of Don de Savigny and colleagues, used by the WHO. But in a more mechanical way, you could do it with all kind of arrows illustrating the feedback loops and the re-emergent loops, etc. I think the most important element of a complex system is that it is pretty unpredictable to know beforehand what will be the outcome of any intervention you do, precisely because it's a complex system. And that is a central recurring theme which comes back when we talk about health system strengthening or interventions within health systems. So yes, then from defining health systems to analyzing what is happening in there, of course the next step is taking action to support health systems or to strengthen them. And the framework on the left is the famous control knob framework, where Roberts et al. Gave some control knobs on how you could influence outcomes in a health system. And a very recent publication, which is in the same line, is the one of Chi and all, where he tries to differentiate between supporting health systems and strengthening health systems. And they have made a framework which they call a health system cube. All of it to be found in the respective publications if you're interested. Our health system dynamic frameworks is basically built up from input processes to outputs, and then very important, we describe the population and the context and how the system as such interacts with it. So this is the framework which I think all of you are familiar with. It has the 6 building blocks of the WHO, but it has much more as well. The specifics of this framework are that there is a central axis recognizable in it, going from leadership through the research inputs to service delivery, which is in our perspective a central element within the health system. That is where the most important processes take place, where we talk about. And then in relation with the population, and finally also targeted towards outcomes. The health system is not a goal in itself, but it are the outcomes and outputs which are the final things which matter. We think that our framework allows for complexity and to analyze complexity, combining functions within a health system and actors in a health system and the processes going on in a health system. I think the way we visualize the health system stresses the dynamic interaction between the blocks and between the functions and the elements of a health system, but also very important between the elements and the context in which a health system is situated. Our central visualization of values as the underlying building block, if you wish, requires to make values explicit when we talk about health systems, and to make explicit which values you favor over others. So the framework has 10 core ingredients, which are all listed here. And in this presentation I will focus on a few of them which are central and which I think have not been touched upon yet by other speakers in your training week or within the coming weeks. So as we said, the framework shows that the health system is really geared towards goals and outcomes. And the final goals of a health system are to improve health with maintenance or even improving social and financial protection. When I think about social and financial protection, a lot is being said by other speakers. I think Gorik Ooms, the other Skype presenter, talked to you about that in length at another occasion, so I won't go into detail. And health, well, as we said, this is the WHO definition of health as something broader than just the absence of disease. So it's not only about DALIs, but it is also something which includes mental and social well-being. Then the one step before final goals are outcomes, and they are very directly linked to the service delivery block. I think the outcomes are the direct result of how you organize service delivery and how well it is. So one of the outcomes of the health system and of the service delivery block is that it should provide universal access and or universal coverage. These terms are used sometimes interchangeably, although they do have differences. And that means that healthcare and the other services which fall within this block should be affordable, reachable, and acceptable. And you see the picture here, which is based upon Tananashi diagram, that there is the target to be reached becomes more difficult at each step. You might have health services available in theory for almost everybody of the population, but then after that is the population able to access the health services physically, financially? Then are the health services provided within those buildings acceptable? If they are acceptable, do people finally actually go when they have a health problem? And you see, you lose people at every step. So even if you have in theory 95% of your population covered by health services provided in hospitals or buildings, then the people making effective use of those health services are in reality, unfortunately, usually much less. The 2008 WHO report talks in length about how do you finance universal coverage of health services, and that tries to answer then questions about the breadth, the depth, and the height of this coverage, which basically relates to the question about which services do you cover, how much co-patients are there, and do you cover the whole population. Well, that is about access to services, but if the services are there, then it's not only about that they are there, but they should also deliver decent quality of care. And quality of care involves the dimensions which are written down here. There are a few which have to do with basic evidence-based quality care. It should be safe, it should be efficient, etc. But more and more also the dimension of empowerment is considered as crucial to quality of care. And especially when we talk about quality of care for people living with chronic conditions, then I think it is essential that we realize that as a health provider, if you want to deliver good care to a patient with diabetes, it's not only about that you give him the effective medication when you're in the consultation, but that you also try to empower that patient or contribute to his empowerment, so that at the moments that he's not in your consultation room, he or she still knows how to deal with that disease. So empowerment is a relatively new but crucial element of giving good care to people. The other dimension which we wrote down here as an outcome is that health services should be responsive to the expectations of the population, and that is at individual levels, to the expectations of patients and of persons when they go to a health provider. So that covers dimensions of treating people respectfully, having them recognize their own dignity, keeping confidentiality, etc. But it also touches upon the dimension of the more community level, the being responsive to what the population as a whole expects the health system to deliver. As technocrats, you might have an opinion, or there are scientifically based opinions about what are the needs of a certain population, and that covers usually vaccinations against major infectious diseases, that might cover antiretroviral treatment, that might cover a lot of services. But at the other side, there is the demand of the population for certain health services. For instance, the opportunity to go to a health service when you have a cough or when you suffer from a certain disease. And in our opinion, responsiveness of the health system is trying to ensure also that these demands or perceived needs of the population cover as much as possible, or overlap as much as possible, with the needs as they are defined by technocrats or decision makers within a health system. There should not be too big a gap between those two. Then I said that values and principles are underlying basics for the whole of the health system, and they are reciprocal in a way with the goals of a health system. Now, there are many values and principles. Some of them are more or less technical, like efficiency and effectiveness, and others have more to do really with ethical principles, such as that healthcare should be a right for everybody, or that you want people to participate as much as possible also in contributing to their own health, or the solidarity within a society. Well, many of these values and principles are aspirational, and we would wish them all to become reality, but there are trade-offs to be made. If you a lot of this, there is a balance in there. Optimal effectiveness does not go together with optimal efficiency, and so it's all about priority setting and trying to justify why you in certain situations value one principle or one value more important than another one. And of course, the ones who make this final priority setting, that has to do also very much with power relations. And if you want to coordinate that process well, that is a part of governance and leadership. We said the central building block is health service delivery. And when we talk about health services, it's more than just curative care. In fact, there is a whole range of functions of which have to be delivered in a health system, going from primary prevention to finally rehabilitation of people who have been struck by disease and can never be fully healthy, quote in quotes, anymore. And to realize all these functions, you need general health services delivering curative care and secondary prevention, but you also need disease control programs, and you need the community. So it's not a matter of favoring one over the other, or of saying we only need disease control programs or general health services. The increasing recognition is that you need all of those platforms to deliver all those functions. I go back now. We should go. So yes, there are a bunch of healthcare services or healthcare products which need to be delivered to people, or which are delivered partly by people themselves. But when we talk about universal coverage, then the issue comes of okay, which ones are more important than others? Because unfortunately, reality teaches us that there's a cost to delivering everything. So policymakers have to make decisions on what they fund, and that's where priority interventions come into the picture. And the choice of what is the package which we should try to have covered for the whole population, that package and that decision should ideally be made within the context and with participation of democratic structures in a certain society. Once you have agreed upon a package of interventions that the population should have access to, then the next step is that you think, how can we deliver these interventions to people in need? And of course, there are many, we call them delivery platforms. A lot of care is done by households themselves and could be done at household level. For instance, the distribution of bed nets to prevent malaria, that could be done very close to people in their daily living. But when you talk about surgery or doing cesarean sections, you will probably choose to limit the number of platforms to hospitals and maybe health centers. So these are usually efficiency and effectiveness arguments which determine the choice for a certain delivery platform. Well, you can make an ideal system of which services need to be delivered at which platform, and then you come to models which were traditionally called district health system, and there are ideas about how you could ideally organize such a system with a minimum of overlaps and a minimum of gaps and an optimal flow from the first line to the second line and the third line. And it's important to think about these things, and it's important to try to steer people using health services as well as people offering health services as much as possible to take this into account. But the reality is also that service delivery is very pluralistic, and that you have health services popping up giving care at all different levels, and health services which are partly owned by the state, but also by other owners, sometimes non-for-profit churches, NGOs, and also more and more for-profit providers, which despite our regulation trying to be in place, pop up at all levels and offering all kind of services, partly out of the control of the state or any other regulating body. So this is to a certain extent spontaneously evolving process of health services coming and offering services to people, and it is a central part of a governing body to try to steer such a pluralistic health system into such a direction that the goals of a health system are not forgotten. So as I said, here above is maybe the ideal picture, where you have a primary healthcare team as the central nod of care, steering patients to all other services as a gatekeeper. But the reality is much more often something much more pluriform and boundaries less vague. I will touch upon shortly also the role of the population. Traditionally, population and people are often seen as the customers or the patients on the receiving end of health services. But we think it's crucial to also recognize that they are very, very important in the supply side also. They are also producers of care in the way they behave, whether they wash their hands, but also in the whole path before they finally go to a service provider, how they seek health care, to which providers they go first. For people with chronic diseases, very important, how do they manage their chronic conditions in the times that they are not in the consultation room. So very important to also think about people as being part of the delivery side of healthcare and producing health by themselves to a certain extent. And of course, by paying taxes, they also fund part of the healthcare, and that gives them an important right to also co-determine what should be the shape of the health system. So important aspects which you could highlight when you talk about the role of the population is how they seek healthcare, what are their demands, and how they are participating and how they are empowered to contribute to health, their own health and the health of others. The context, we already said that every health system, health systems are not placed within a vacuum. They are part of a certain society. The way they are shaped is determined by the history of that society. We call that path dependency. So how a system looks, how the health system in the United States looks like, has to do with historical events also, and the way how it looks in Europe, with a big role for hospitals and for professionalism as an important steering factor for how doctors behave. That has grown historically by the role that doctors had as a group within the society. At the same way, now the growing role of a lot of private and partly informal behavior, informal providers in a lot of low-income countries is also has a history and is path dependent, is determined by decisions and processes which happened in the past. So when you want to strengthen health systems, you have to take this context into account. And taking a blueprint approach from Europe to try to introduce into a health system in, for instance, Burundi, will not work without knowing why the health system in Burundi is shaped as it is today, taking into account its past. So it's much more steering than completely building from scratch. So deep analysis of the context and of the transitions within the society and of the national policies and of the national stakeholders is crucial when you think about intervening and steering in a health system in a particular country. This is a central element of leadership and governance, but I wouldn't go too much into detail here because I think you have touched upon that in other presentations. The same goes, in fact, for financing and all the other building blocks which are covered in resources. I show the World Health reports which have been devoted to this particular elements of health systems, but we won't go into detail here. coming all again back to the framework. This is the synthesis of the presentation and how we visualize the health system as such. So this is the framework again, and you can, in fact, when you load it with certain values and with things which you find important, then it gets meaning. When it's still empty, you can adapt it to the analysis of a particular problem. But what I did here is in yellow, make explicit what we think is important, and that is a loaded framework. It's no longer neutral, it's no longer empty, but it says something about how we here in the Antwerp School of Thought think that health systems should try to look. And we already said there's the central X with leadership, governance, delivery of health systems, interaction with the population. We think that if you talk about leadership, priority setting in the country is crucial instead of bringing blueprint approaches from outside. We think that the resources are an input, but human resources and finances are crucial elements in how the health system is shaped. And human resources, when you talk about that, you talk about the availability, about the competence, but also about the motivation of people working in the health system. I already talked a bit about the interaction with the population and the values and the principles, that it's important to clarify which choices you make in the balance about which values way more important than others. That was the presentation of the framework as such. You all know the framework, I think, or after this presentation you know it maybe a bit better. Many of you, I have learned already through emails from some of you, have been using the dynamics framework already in their own master thesis or PhD work, and we are very glad to hear that. We made this framework also because we thought it very useful for our own teaching purposes, and we've seen that it's illustrative to explain what the health system is. So yes, how can it be useful for you and for colleagues in the field, this framework? Well, we already said it can help you to analyze and even compare health systems, your own health system at national level, but even at the district level. You can adapt the framework to describe the system within your own district and look at the different levels. It could also help you to look at interventions with aim to strengthen health systems. But if you load it with certain values and objectives, then it becomes more framework which shows what you prioritize and what you find important. It can be a decision aid also in trying to predict what might happen and what might be the effects on other blocks if you make an intervention in a particular building block. And then finally, it can be used to clarify things for students and be an aid for teaching. So this was the short overview of the dynamics framework. The quote, I know that a lot of the discussions within the symposium will be about research, about analysis, but for people devoted to action, a lot is also about how can we improve health systems. And then I would like to quote once again my colleague Bruno Mason in his recent editorial in the Bulletin of WHO, that any intervention you make in a health system is never simple. The context matters a lot, and the intrinsic complexity of health systems really resists blueprint approaches and homogenization. The context matters a lot, And the context matters too. For instance, if these babies in the left upper corner are probably in a low-income country, to see from the Kangas, they were born in an African country, that they were better born within a hospital. And here right down is my own baby, which I delivered 6 weeks ago, and I delivered that baby at home. But the context in the Netherlands, where I was 5 minutes away from a hospital when it was needed, made that in that context, good service delivery was that I could deliver at home, and that for the babies left, it was probably best to be born in a hospital, just to illustrate how you cannot make universal truths about health systems interventions in general, but that you have to take into account the environment in which health systems are situated. Thank you very much. I hope to go into discussion with some of you to touch upon more concrete issues and specific questions later. Enjoy the conference.